Good morning, everybody. Today we will discuss beta-lactam antibiotics, and this will be in two sessions. So today we will discuss only the penicillins. What do we need to study in antimicrobials? What are the objectives of this session? Remember, in all antimicrobials, the objectives are slightly different from rest of the pharmacology. In antimicrobials, we want to know about what is the basic nature of that group of antimicrobials, what is the mechanism of action, what is the spectrum of activity of that antimicrobial that is different from rest of the drugs in pharmacology, and what are the uses. Naturally, the uses would be based on spectrum of activity only. If a drug does not cover a particular organism, it cannot be used to treat that. And what are the adverse effects? So these are the questions. Normally there are questions on resistance also. So resistance, we may have a separate session also, or we may discuss along with these topics, that depending on the time. So these are the objectives of this session, and these are the questions you are frequently asked. What is the mechanism of action of this drug? What are the uses of this drug? What is the spectrum of antimicrobial activity? What are the adverse effects? So these are the questions which are asked. Sometimes in Viva also you may be asked whether this drug is acidic or basic, what is the chemical nature of this drug. So we should have gross idea about, like, these are beta-lactams, they are sulfonamides, they are sulfa drugs. So we should have some basic knowledge about the chemical nature or physicochemical properties of that drug, because that will decide pharmacokinetic properties also. So we'll start with the penicillins. First of all, penicillin. Remember, this was the very first antibiotic that was used. There were sulfa drugs being discovered since 1920s, sulfanilamide and others, but this was the antibiotic. What is antibiotic? Some antimicrobial that is derived from microbes. So all are antimicrobials. Any drug that is effective against microbes is antimicrobial. But when it is derived from microorganisms, then we call it antibiotic. So this was the first antibiotic, and this was a great discovery. Remember, antimicrobial is, I consider it as important a discovery like anesthetics, general anesthetics. That was a phenomena. Antimicrobial discovery was a phenomena that changed everything in modern medicine. Allopathy, it changed everything. I won't call it allopathy at that time, this was modern medicine. So this changed so many things. Remember, there are so many factors behind the development of a drug. So we call it a serendipity. By chance, the Fleming observed it. But what happens after that? Remember, it is said that Second World War was won by penicillin. The people, the soldiers who were killed in action were less than those who were killed in trenches because of infections. And this was the time when penicillin was introduced. So whoever had penicillin would win, and this was the strategy in Second World War. So this has a beautiful history. You should go into what it takes to develop a particular drug and how it becomes popular and how it is produced at a large scale. What is penicillins? As I told you, they are beta-lactam antibiotics. Beta-lactam. See this structure. I've taken it from the book. Could have drawn. This is thiazolidine ring. This thiazolidine ring, position 1, 2, 3, 4, 5. 6 and 7. Thiazolidine, because it has this S. So this is thiazolidine. And this is known as beta-lactam ring number 1. So this starts 6, 7. And this CONH attached with a side chain R. Here you have this COOH. These are important parts in this structure. When we see these drugs, these are acidic drugs, so they bind with positively charged ions like sodium, potassium, and where do this bonding takes place? That is at this position. These positively charged ions would bind it at this place, and we should have, just like I told you, basic nature, whether this is acidic, this is basic. This is a classical example of acidic drug, penicillins. So on this side we attaches side chains, and that is how we get so many semi-synthetic compounds. So all of them are attached here. What is the active moiety as an antimicrobial in penicillins? We call it penicillinic acid. Penicillinic acid. And what is that? You remove this and this will become NH2. So on this side NH2, here COOH. That is penicillinic acid. That is the active molecule of this antimicrobial. So this much you should know. And this beta lactamase is very popular. That is an enzyme that causes degradation of penicillin. So where does that act? We call it beta lactamase esterase. It is an enzyme. So it acts here, and this will become COOH and this will become NH2. So hydrolysis will take place. Okay, and then this will no more be an antimicrobial antibiotic. So this is broken at this place by beta lactamase. So in the structure you should remember at least these points. Just like I told you, they are acidic drugs, and penicillin, remember there's something known as natural penicillin. Natural means derived from the mold, and it contains benzyl at this position. Benzyl, remember that benzene ring, C6H5. So when it contains this benzyl at this position, then we call it benzyl penicillin G. That is the original penicillin excreted by kidney. Around 10% is excreted through filtration, and rest of it is secreted in the nephrons. This is important because there are acid ion transporters in the nephrons. They secrete it into the lumen of the nephron, and that is how it is excreted. We utilize it clinically by giving probenecid. Probenecid is another acidic compound that competes with penicillin for secretion. Two acidic drugs will compete for secretion in the nephron because this is an active transport. Acid ion transporters, we call them. There are basic ion transporters also, but there are very few interactions in basic ion transporters. Most of these drug interactions are in acidic drugs. You have interaction of aspirin with uric acid. They are all acidic. So they will compete for each other. Warfarin, we keep giving examples of warfarin, another acidic drug. So remember, these drugs are 90% secreted. That is why we use probenecid. When we give probenecid, the secretion of penicillin is decreased and the plasma concentration will increase. Remember, this drug has very short half-life, less than half an hour. And that is why if you see, we will have to keep giving it all the time, or you'll have to go for infusion. But we have found out the mechanism to administer, and that is another reason that this was very first antibiotic, and this is the safest antibiotic, I can call it. That was again by chance. And so what we do, we give huge amounts of penicillin so that plasma concentration that is achieved is very high compared to what is minimum inhibitory concentration. So even if plasma concentration keeps coming down, we would be required to administer only 3-4 times every day. So natural penicillins are excreted through kidney mostly by secretion. This is the mechanism of action. We'll talk about other parts of other drugs, about pharmacokinetics also. Remember, this again I have taken from a book, NAM, N-acetyl muramic acid. Remember, bacterial cell wall is a rigid structure. It is required because the concentration inside bacteria is very high and surrounding is less, so hyperosmolarity in the organism. If this rigid cell wall is not there, the organism will swell, will burst. So it needs this cell wall. This cell wall we call it peptidoglycan, means glycan and peptide. Glycan is polysaccharide. Polysaccharide is this NAM, NAG, NAM, N-acetyl muramic acid, and N-acetyl glucosamine. Alternate. They are layers of these polysaccharide. Remember, this pentapeptide is attached with N-acetyl muramic acid. This pentapeptide is what? Agla. Alanine, glutamic acid, lysine, alanine. And you have to remember LND also, LDL. L-alanine, D-glutamine, L-lysine, and DD-alanine. So LD-LDD. This is how you can remember it. This N-acetyl muramic acid attached with this pentapeptide is the basic structural unit of cell wall. This is known as Park peptide. This is the structure of this cell wall. And now remember, these plates of this peptidoglycan are layered above each other, but they will separate, so they will not act as a structure. So cross-linking of these peptide chains, it takes place with the help of transpeptidase. What transpeptidase does? This removes this D-alanine, and this way it becomes active. Active in the sense the other D-alanine is ready to transpeptide with, to form a bond with L-lysine, and in between there is this pentaglycine chain. So one is this pentapeptide, another is this pentaglycine, another is this pentaglycine. So this pentaglycine will bind the L-lysine with the fourth D-alanine. This D-alanine is removed, and then next thing again will happen. This D-alanine will also be removed, and then this D-alanine will bind to L-lysine of next pentapeptide. So remember, one pentapeptide is this agla and another is pentaglycine. This pentaglycine will bind L-lysine with D-alanine. So this is what happens, and a structure is formed. That is cell wall. Now this pentapeptide is an enzyme, and along with some other, this we call penicillin binding protein. This is penicillin binding protein, PBP. This transpeptidase along with some other paraphernalia is known as penicillin binding protein, and penicillin inhibits it. When this is inhibited, naturally this cross linking will not take place. of these peptide chains, and when cross-linking is not taking place, that means the cell wall is not being synthesized. Naturally, we can imagine if an organism is already fully developed, working, then it would not make any difference to it. Already the cell wall is there. But when the new microbes are produced, they need active division of this cell wall, synthesis of cell wall. So this would be more effective in actively multiplying organisms. And in actively multiplying organisms, this acts as bactericidal, because these organisms will not be able to maintain the osmolarity. They will swell, and actually when they swell, they give unique structure, filamentous, giant cells, unique structure. And now they are trying to find out that if which, remember these transpeptidases, there is a variety of them. Now we can find out. So it is now being discovered that different type of transpeptidases, when we block them, it gives a different shape, like carboxypeptidase it is said, or various isomers of this protein penicillin binding proteins. But just remember, the organism will not be able to maintain osmolarity. This will absorb water from the surrounding, this will swell, this will burst. So this is how it acts. This is a difference. We say that penicillins are effective more against gram positive compared to gram negative. This is the reason. In gram negative, there is an outer membrane also compared to gram positive. In gram positive, the outermost layer is cell wall. Cell wall is outer side of plasma membrane. But in gram negative, there is a basic difference. There is another difference also, that this cell wall is very thin also. But remember, this outer membrane is there, and this membrane normally is not permeable to penicillin. So penicillins are not able to reach the cell wall. There are these channels, we call them porine channels. So only through them they can. And now we have some drugs which are active against gram negative also. We call them extender spectrum. They are more hydrophilic, smaller in size, so they can cross this porine, and that is how they are effective against gram negative also. But remember, in gram negative, there is an outer membrane that has very small porines. Penicillin cannot cross them. That is why it is not effective against gram negative. Against gram positive, it has direct action. These penicillin binding proteins are accessible to the drug. What are the kind of drugs that we have? We call it classification, another favorite question of everybody. Which are the penicillins do you have, or classify penicillins? So this is one of the types you can remember. Naturally, I told you they are narrow spectrum, effective against gram positive only. The reason I have told you. So narrow spectrum, and another thing is beta lactamase becomes very important. So either the penicillin can be beta lactamase sensitive, or it can be resistant to beta lactamase. We have developed some of the semi-synthetic compounds which are resistant to beta lactamase. So remember, these are narrow spectrum, beta lactamase sensitive. I told you the natural one is penicillin G, benzyl penicillin G is the natural one. These are also procaine penicillin, semi-synthetic. Procaine penicillin, you add procaine to penicillin, this increases the duration of action. So we give it once a day. Procaine penicillin is given once a day, but it is not, remember, penicillin, original natural penicillins are not effective orally. Another important factor, acid labile. So this is acid labile, cannot be given orally. Procaine penicillin, acid labile, cannot be given orally. Benzathine penicillin is, we add benzathine with penicillin, and then we give depot preparation intramuscularly. The effect remains for 2 to 3 weeks. So this is a long acting penicillin, again acid labile. And then we have phenoxymethyl penicillin, we also call it penicillin V. This is like natural penicillin, but it is given orally. This is acid resistant. Phenoxymethyl makes it acid resistant. So amongst these narrow spectrum, natural we can call them. Natural penicillins, this is orally effective, these are not orally effective. So this is acid labile, this is acid resistant, and these three are acid labile. This you have to remember. Then in narrow spectrum only, beta lactamase resistant, we also call them anti-staphylococcal, because beta lactamase, when initially this was found out, this was mostly produced by Staph aureus. They become resistent very fast, and so we also call them anti-staphylococcal. Remember, cloxacillin, dicloxacillin and flucloxacillin, they are acid resistant. Acid resistant. These three, cloxacillin, dicloxacillin, flucloxacillin. These methicillin and nephicillin, they are acid labile, they cannot be given orally. So this you can remember at the same time when we are talking of beta lactamase resistance. So anti-staphylococcal, these are acid resistant, so they are given orally. Methicillin and nephicillin are acid labile, so they cannot be given orally, and nowadays methicillin is almost obsolete because of interstitial nephritis this causes. But we take it as a prototype because there is something known as MRSA, methicillin resistant Staph aureus. So the term is retained, but when we say methicillin resistant, that is resistant to nephicillin also. Okay, so we use the term methicillin resistant even today, MRSA or MSSA, methicillin sensitive Staph aureus, and so we have to include it. But otherwise methicillin is no more used nowadays because of its toxicity. And then we come to, I told you about extended spectrum. Extended we call it because they are effective against gram-negative organisms also. The reason I told you, like ampicillin, this is very hydrophilic in nature. This can cross the porins, and this is effective against gram-negative also. So in extended spectrum, there are three categories. One is aminopenicillins: ampicillin, becampicillin, talampicillin, amoxicillin. Becampicillin, talampicillin are products of ampicillin only. In the body, they are converted into ampicillin. So grossly, you have ampicillin, amoxicillin. Okay, ampicillin is given if ideally you have to give 4 times a day. Amoxicillin is given 3 times a day. And it is said that amoxicillin has less diarrhea, ampicillin has more diarrhea. I don't agree with that. With amoxicillin also, people have lot of complaints of diarrhea, but comparatively amoxicillin is better. These are extended spectrum, we call them anti-pseudomonal. There are 2 categories, one is carboxypenicillin, another is uridopenicillins. Carboxypenicillins are carbenicillin and ticarcillin, and uridopenicillins are piperacillin, magellocillin, azellocillin. So these many drugs you have to remember. I told you narrow spectrum. In narrow spectrum you can divide them into 2. One is beta lactamase sensitive, another beta lactamase resistant, and keep a track of acid labile and acid resistant. And then you have extended spectrum that has 3 varieties: aminopenicillins, carboxypenicillins and uridopenicillins. Beta lactamase resistant narrow spectrum we call them anti-staph, and these extended spectrum we call them anti-pseudomonal. Remember, extended spectrum are beta lactamase sensitive. They are beta lactamase sensitive. So beta lactamase resistant drugs, you have only those cloxacillin, dicloxacillin, flucloxacillin you have. So methicillin, nephicillin, they are the only beta lactamase resistant drugs. This is how actually semi-synthetic and synthetic we give in grams, like ampicillin 500 milligram, amoxicillin 500 milligram. But the natural penicillins, when they were produced, they were administered in units. So that also you should have some idea. 1 milligram gives you 1600 units. Another question that is asked in Viva. So 1 milligram is 1600 units. That means 1 unit is 0.625 microgram. That means 625 milligram is equal to 1 mega unit. We call it MU. Nowadays the use of natural penicillins had decreased a lot, but in our days I used to use a lot of procaine penicillin. 3000 international units procaine, 1000 benzyl penicillin. These are a combination of 4000 units. So 4 lakh units. So this was the, now mostly you have semi-synthetic and synthetic compounds which are given in milligrams. Always remember, try to study spectrum and therapeutic uses simultaneously, because as I told you, if a drug is not effective against any organism, this cannot be its use. So it's always better, and you remember, sometimes you remember the use so you can remember the organism, sometimes you remember the organism so you can remember the use. So this is how I remember them, and that is how I do it. So spectrum and uses. First of all, let us talk of natural penicillins which are narrow spectrum. Narrow spectrum, beta lactamase sensitive. So that is the natural spectrum of penicillins. Narrow spectrum we call it. So narrow spectrum we say gram positive. So gram positive, grossly you should have a working classification with you, and in working I always remember gram positive cocci, gram positive bacilli, gram negative cocci, gram negative bacilli, and then some aerobic and anaerobic nature of those organisms. This is the working classification. In pharmacology we have to remember if we want to remember the spectrum. So these natural penicillins are effective against gram positive cocci, and which are those? Very common cocci, Streptococcus pyogenes, that causes pharyngitis, otitis media in children. All these upper respiratory tract infections, they are caused by Streptococcus pyogenes penicillins. These are the sensitive organisms, and these are the uses, therapeutic uses I have written. So this is how you can remember it. Another, gram positive Streptococcus pneumoniae, that causes pneumonia, community acquired pneumonia. Effective penicillins, they used to be drug of choice. Enterococcus, remember enterococcus is also, there's something like enterococcus, another is enterobacter. Enterobacter is different, that is opportunistic infection. Enterococci are basically Streptococcus, viridans Streptococcus. These are the family of Streptococci, that we call it enterococci. They cause subacute bacterial endocarditis. Very effective penicillin. Ampicillin also effective. We don't use them alone, we give them along with gentamicin. Remember, here also I am not talking much about how these diseases are treated. That you'll have separate session, prescription writing or something. Here I am just concerned about, you have to write the therapeutic uses of penicillins. How that disease is treated may be a different thing. You may have to add another drug, you have so many alternatives. But when it comes to therapeutic uses, you must enumerate all therapeutic uses. You cannot say this is not the drug of choice now. That is not the answer. The drug is effective, so it is one of the therapeutic uses. You don't use it because you have better choices. That does not mean that it is not effective against it. SABE, beta hemolytic streptococci, rheumatic fever. Remember? So they are effective against that also. Then gram positive, so these were gram positive cocci. Then gram positive bacilli, these are important ones against which is effective. Clostridium tetani. Now you can say that in tetanus we have to use toxoids also, we have to use this also, that also. Yes, you need to use so many other methods, but this is the therapeutic uses of natural penicillins. Perfringens, that causes gas gangrene. These are two Clostridia we have read. Tetani and perfringens, it is effective and very effective against these. Corynebacterium diphtheria, it is not Clostridium. Corynebacterium diphtheria, that causes diphtheria, effective. Bacillus anthrax, actually this is the drug of choice even today. Listeria monocytogenes, which cause meningitis, listeriosis, effective. Treponema pallidum, actually even today, this is the drug of choice. Syphilis, you have a beautiful history, I shouldn't call it beautiful, you have very interesting history of treatment of syphilis and how people, they suffered because of syphilis. And how these clinical trials were conducted on syphilis of penicillin. Check out. Gram negative, remember gram negative, extended spectrum. Natural penicillins, they may not be, but remember, it does not mean that it is narrow spectrum, so this will not be effective. Even natural penicillins, they can be used in these conditions, but you have extended spectrum, they are more effective, and that is Neisseria. The two of them you have to remember, Neisseria meningitis and gonorrhea. Meningitis causes meningitis, gonorrhea causes gonorrhea. These are the drugs, very important drugs. And there again I am telling you, amoxicillin may be more effective against gonorrhea, or other penicillins may be more effective. I am talking about therapeutic uses. This Israeli organism, craniofacial, thoracic, abdominal abscesses, cellulitis and others. So these are gram negative bacilli. And then we come to beta lactamase resistant. As I told you, they are effective against all those which were sensitive to natural ones. In addition to that, Staphylococcus. Staphylococcus causes osteomyelitis, septicemia, endocarditis, cellulitis, so many things it does. So in addition to that spectrum, you have to add this, and this becomes your therapeutic uses of beta lactamase resistant drugs. Then extended spectrum penicillins. In addition to what you have learned till now, these are the organisms which are, that is why I told you natural penicillins, they are also effective against Neisseria meningitis, though we may not use it, but it is sensitive. This is the additional spectrum of extended spectrum, and this is another question that is asked. Which are the organisms sensitive to extended spectrum and they are not covered by natural penicillins? Why do we need extended spectrum? Why do we call them extended spectrum? These are the organisms. Pertussis, Bacillus pertussis causes whooping cough. Influenzae, H. influenzae, this causes your pneumonia, otitis media, sinusitis. E. coli causes UTI, causes gastrointestinal infections also. Proteus mirabilis causes UTI. Shigella causes dysentery. H. pylori ulcer, you have read it, amoxicillin is given. Salmonella typhi, these are, remember, amoxicillin used to be drug of choice for Salmonella typhi, though now it has changed a lot. Then came ciprofloxacin and then other drugs, but this was the drug of choice, and even now in many areas this retains its sensitivity. So these are the organisms which are covered by extended spectrum, which are not covered by natural penicillins. Then these uridopenicillins and carboxypenicillins, they have this additional spectrum, we call them anti-pseudomonal. Pseudomonas aeruginosa, opportunistic infection, and this can be lethal actually. Hospital acquired infections, Pseudomonas. And septicemia is the biggest problem. You have indole positive Proteus. Remember, one was Proteus mirabilis. Here it is indole positive. Extended aminopenicillins are not effective against indole positive Proteus. These drugs are effective. Klebsiella pneumoniae causes pneumonia, effective. Enterobacter I was talking about, this causes UTI, RTI, so many types of pneumonia, septicemia, very dangerous. So this is the spectrum that is covered by anti-pseudomonal. So this is the way you can remember is, one is the spectrum of natural, second is addition because of beta lactamase resistant organisms, third is because of extended spectrum, more spectrum is added, and then comes these anti-pseudomonal. So these with Pseudomonas you have to remember indole positive Proteus, Klebsiella and Enterobacter. So they add into that. Then we come to resistance to penicillins. Though we may have a separate lecture on resistance to antimicrobials, but here because there are some drugs which are available, so resistance develops because of beta lactamase. I told you beta lactamase can be of two types. One is the one that is transferred by plasmids, another is transferred by chromosomes, another is basically that is known as inducible. So the changes in chromosomes that take place, and another I told you carried through plasmids, R factor. So beta lactamase is one of the mechanism of this narrow spectrum. These are the drugs which develop resistance to this narrow spectrum. Narrow spectrum is what? Remember, one of the differences I told you, that is transmitted through plasmids, another is inducible, that is chromosomal changes. But this also, when I say narrow spectrum, that means this is substrate specific. If the resistance develops to penicillin, then only penicillin resistance will be there. In broad spectrum, once the resistance is developed, then all beta lactams become resistant. Cephalosporins also, monobactams, all of them will become resistant. So this narrow spectrum resistance is seen in Streptococcus pneumoniae, E. coli, H. influenzae, and these organisms, Pseudomonas, Enterobacter, Citrobacter, Moraxella catarrhalis, they develop this wide resistance. So once they become resistant to all beta lactam, then you have to go for something else. In these cases, if the organism is resistant to amoxicillin, you can go for cephalosporin. In this case, you cannot do that. So remember this. Another mechanism can be modification of protein binding, penicillin binding protein. Make some changes in that. Third is reduction of penicillin permeability. You don't allow the amoxicillin to permeate in gram negative. Activation of antibiotic efflux mechanism. Push it out before they can act. So these are all mechanisms which are found, and remember the resistance to penicillins has been studied in detail. So all these mechanisms can be seen. Beta lactamase inhibitors, they are also, we have 3 drugs available. They inhibit plasmid mediated and not chromosomal mediated. So if the organism is resistant to all beta lactams, then you cannot do anything. And we have 3 of them. One is clavulanic acid, sulbactam and tazobactam. Okay, because of pharmacokinetic characteristics, we have developed the fixed dose combinations with these, like clavulanic acid is available with amoxicillin, amoxiclav available as 625 milligram tablet, 500 milligram amoxicillin, 125 clavulanic acid. Clavulanic acid, remember, is a natural product derived from Streptomyces clavulicera. Clavulicera, this is the organism that gives us clavulanic acid. These are semi-synthetic compounds. So sulbactam we add with ampicillin, 1 gram with 0.5 gram, and tazobactam with piperacillin, 2 gram of piperacillin is added with 125 tazobactam. This is available. Piperacillin is not available orally. I have told you this is acid labile, anti-pseudomonal. Okay, these are available. Even this is available for parental use only, sulbactam also. So orally you have amoxicillin and clavulanic acid combination. Now if we add clavulanic acid to amoxicillin, then what happens? What is the advantage? These are the organisms which otherwise have developed resistance because of beta lactamase. So when we give amox-clav combination, then these organisms are covered. Otherwise natural penicillins, they have remained sensitive to only a very few organisms. Rest of them, they have developed beta lactamase, plasmid mediated. Streptococcus pneumoniae, so only amoxicillin nowadays is not effective. H. influenzae, only amoxicillin not effective. Moraxella, catarrhalids and some other organisms also. Methicillin sensitive Staph aureus. Methicillin sensitive, not MRSA. MRSA is sensitive to other drugs. Klebsiella, Neisseria, alone to amoxicillin. Otherwise, we used to give a single dose of ampicillin 3.5 gram. This used to be very effective. Now resistance has developed. So Neisseria, beta lactamase producing anaerobes, and these are E. coli, Proteus, Klebsiella. These are the organisms which have become sensitive to amoxiclav. Otherwise, if you remember in original classification, I have covered them as sensitive to penicillins, but gradually they have developed resistance. So they become sensitive if we add clavulanic acid. Adverse effects are very few. Best part. Most important even today, we keep saying hypersensitivity reaction, because this is one of those drugs for which we have to go for sensitivity test before you administer it when you give parenterally, and we used to do a lot. When I was an intern, this used to be one of the important duties. I used to put them in line, give injection 2 to 10 units you give. Remember, this hypersensitivity reaction can be because of this small amount also. When you are testing, reaction can be there. Remember, these reactions also can be 2-3 types. One is immediate type of reaction, that is mediated by IgE. Hypersensitivity reaction, you develop pruritus, urticaria, angioedema, sneezing, rhinitis type picture, but in severe cases, though very less, we can call it 2 to 4 in 10,000. So, but angioedema means you will have swelling in your mucosa, and that will cause respiratory problems, and ultimately it may lead to death also if not treated. But treatment, adrenaline you give, naturally you have a prescription for that. If you adrenaline, you give corticosteroids, antihistaminics, that is taken care of. That is immediate. Another is that is developed after or within 72 hours. Not immediate, but within 72 hours, within 2-3 days, you develop this reaction. Mostly you have skin rashes, urticaria rashes, pruritus. So that is, and third one is delayed after 72 hours also. You can have, actually this can be this, you can have this reaction with many drugs, not only with penicillin. Morbilliform rashes, there may not be pruritus. Morbilliform rashes on the trunk, front and back, severe rashes, maculopapular rashes, there may be itching or there may not be itching. So these are skin reactions which are delayed. IgE, IgM, both are involved in this delayed reaction. So all these hypersensitivity reactions can be there. Remember, if you give very large doses, and sometimes suppose procaine penicillin rather than intramuscular you have given IV, then also you can have reactions. In case of procaine penicillin, that reaction is because of procaine, not because of penicillin. Procaine can be very toxic if you administer it by mistake intravenous. But if you give as per rule also, and you give suppose very high doses, then there can be toxicity, neurotoxicity. There can be even convulsions. It may start from headache, but there can be even convulsions. That is why intrathecal administration of penicillin is not advised. Remember, these are the drugs which are distributed extracellularly. Penicillin, if it comes to, we forgot about pharmacokinetics. It does not penetrate CSF, it does not penetrate aqueous humor, it does not penetrate synovial fluids. So we call it, it is distributed extracellularly. 40 to 60 liter would be the volume. And so it should not be effective in meningitis, because it will not reach there. But remember another rule, in inflamed areas the penetration becomes free. So in meningitis, concentration would be very high in CSF. In synovitis, concentration would be very high in arthritis, in synovial fluid. So when inflamed membranes are there, then it crosses, and so it is effective in those conditions. But that is why actually we don't need to give it intrathecally. If the inflammation is there, meningitis, why else would you give penicillin? The indication is meningitis. So in meningitis, otherwise also it is permeable, and so you need not give intrathecally. But if you give, neurotoxicity is another problem. GIT effects, I told you, amoxicillin is said to be better compared to otherwise when you give it orally, diarrhea is maybe limiting. Even with amoxicillin, I am telling you, there can be severe diarrhea, and you have to stop the medication. You have to go for some alternative. This Jarisch-Hexamer reaction in syphilis, you have huge load of Treponema pallidum. When you give penicillin, because this is very effective, all those organisms are broken down, and this develops, there is flood of those parts of that organism, and that causes severe reaction. It becomes very difficult to decide whether this is hypersensitive reaction because of penicillin or because of effect of penicillin. We call it Jarisch-Hexamer, but it becomes very difficult to write the spelling in the exam. So Google facility is not there. So to me it is Jarisch-Hexamer. That is how I remember spellings. So it becomes Jarisch-Hexamer. It is Jarisch-Hexamer. Oxacillin causes reversible elevation of SGOT, SGPT. Methicillin, I told you, it is no more used because of interstitial nephritis. Carboxypenicillin, they can increase prothrombin time, bleeding, reversible. But bleeding can be there with carboxypenicillins. And high doses, I told you, it can be neurotoxic of penicillins, particularly natural penicillins. Very high doses can be problematic. Thank you very much. In the next lecture, we will cover the remaining part of beta lactam.